Hello, my name is Nicole Lamanna, leukemia specialist, CLL director at Columbia University Medical Center in New York, New York. Today, I'm going to talk briefly about the BTK management and side effects of some of the BTK toxicities that we see. We had a very nice presentation at ASH for the educational portion that looked at some of the toxicities that we see commonly with the BTK inhibitors. Ibrutinib and acalabrutinib are the first two BTK inhibitors that are approved for CLL. Zanubrutinib is approved for mantle cell lymphoma, and there are advanced clinical trials in CLL as well. But as we know, these are common medications that we use on a daily basis for our CLL patients, and there are certain toxicities that we see on a routine basis. I think most of us are familiar with the cardiac arrhythmias, such as atrial fibrillation, but we also see fatigue, arthralgias, hypertension, infection, some dermatologic changes. I think these are the common things we see on a routine basis, and how to manage them can be sometimes a little problematic, sometimes pretty straightforward. And I think that it's important because the real-world data suggests that many patients may stop these medications due to some of these side effects, rather than due to progressive disease. So it's really, really important to try to manage our patients with these side effects so that we can maintain the patients on these drugs that are very efficacious for the disease. And of course, there's some randomized head-to-head studies that are still cooking, and we're waiting those data to see if the second generation BTK inhibitors may have less side effects than ibrutinib. So there is a randomized ibrutinib versus acalabrutinib, there's a zanubrutinib versus ibrutinib, to see if any of the adverse events might be a little less with the second generation. And of course, then we have clinical trials already running in some of the non-covalent BTK inhibitors as well. So let's talk a little bit about atrial fibrillation. And in some of our earlier clinical trials, this was not noted to be as frequently as we've seen with longer follow-up. So some of the earlier clinical trials were under 10%. Now we're seeing, more upwardly, probably about 15%. And so there absolutely is a higher rate of atrial fibrillation. And of course, age is an important risk factor in this. And sort of getting an idea about your cardiovascular risk status of your patients, actually may play into that role as well, because there's a higher prevalence in our older patient population, and if they already have a history of hypertension or other comorbidities that might make them more at risk. But how do we manage them? So for patients who have new onset AFib, certainly there are many scoring systems to look at their risk of stroke, and you can sort of do a scoring system, and certainly if they're at a high risk for stroke, you might want to hold the BTK inhibitor. If at a low risk, you might want to continue and then co-manage the atrial fibrillation. And we often consider beta blockade often as preferred choice over some of the CYP3A4 inhibitors, such as verapamil and diltiazem, because they can obviously interact with the BTK inhibitors. And then when we talk about anticoagulation, so if you're going to anticoagulate your patients, strategies typically include low dose apixaban or enoxaparin. Where possible, try to avoid combination with vitamin K antagonists. Okay. And then what about bleeding risk? So that's another risk we see in our patients that can be on the BTK inhibitors. And severe bleeding is usually relatively uncommon, but minor bleeding such as petechiae or bruising are relatively common, and that doesn't constitute the need to stop therapy. So just keep that in mind, that patients can continue if they have some bruising or bleeding. But if they have any major or minor procedures that are pending, so any surgical procedures, remember that you have to counsel them to hold the BTK inhibitors. So if they're having a minor procedure, you might be holding for several days pre and post. If it's a major procedure, you might hold up to a week or before and a week after a major surgical procedure. And if you think in planning with your patients, if they're about to start a BTK inhibitor, you can ask them, are there any planned or upcoming surgeries? Is there minor dental work or things that need to be done? Let's see if we can get that done first. So that's ways to counsel your patients about some of the procedures. And I always remind them to tell you if they're going to be having a procedure. And it's also important to remind your patients to abstain from over-the-counter supplements that may exacerbate bleeding, such as vitamin E or fish oils, because I think we forget sometimes about some of the the things that they may take that are not, on their medication list, and it's always important to include supplements. So I just want to mention briefly about infection in our CLL patients, that it's always common and needs to be evaluated for regardless, and certainly being on therapy with BTK inhibitors, you can see infections on BTK inhibitors. In your relapse refractory population, think a lot about whether or not they have any opportunistic infections and whether or not you need to prophylax for any opportunistic infections, particularly if they've had they're multiply relapsed and had more than one therapy. And then I think briefly, just two other main side effects that we need to talk about, I think, that happen a lot is hypertension. So hypertension does happen on the BTK inhibitors. It's one of the side effects that even happens on the second generations and can increase over time. So make sure you're either co-managing with their primary care physician or their cardiologist if they need to be put on blood pressure medicines, whether you're doing that or doing that with their other physician, absolutely co-manage that. If they already have hypertension, make sure their therapy is optimized before starting a BTK inhibitor. And then the more lingering issue that's harder for us to deal with is arthralgias or joint issues. And there's a lot of anecdotal data about magnesium supplementation, over-the-counter medicines, anti-inflammatories. I think these are all fine to try on our patients. And certainly most of those side effects get better over time. However, there are some patients where this could be very debilitating and persistent and lingering even later on in therapy. And that's when you have to decide if you're going to dose reduce and hold the therapy to see if the arthralgias and the joint and the myalgias go away and better with time, or if you need to switch therapies even to a second generation or switch therapies altogether if they cannot tolerate or they don't improve with supportive management. So again, please see the ASH educational updates. There's chapters about BTK management of toxicities for a more thorough discussion about BTK toxicities in general. And thank you for watching.